to Maternal Medicine Specialists of Nigeria. Today's webinar is I think it should be the 5th or thereabouts. I'm not sure of the exact figure now. But then this afternoon, we're going to be having a talk by our own dear president, Professor Bosede Afolabi, who will be talking to us today on the evidence-based management of sickle cell disease in pregnancy. So we are happy to have you here. Professor Afolabi, you have the floor, ma'am.
Thank you very much, Professor Raji. I'm grateful to have been asked to speak on this topic. And I want to start by saying that I appreciate those who have joined. This is the evening after all. And to lend time to learning is always a positive thing. I know that some people will join later, but it's important to start early because there's a lot to say, but I'll try to reduce it as much as possible. As said, my name is Bosede Afolabi. I'm a professor of obstetrics and gynecology at the College of Medicine, University of Lagos, and the Lagos University Teaching Hospital. I head the department as well, and I'm also the president of AFEMSIN. One of my areas is in sickle cell disease in pregnancy. I have also worked in the areas of anemia in pregnancy, cardiovascular diseases in pregnancy, and maternal medicine generally. Today, I'm speaking on the evidence-based management of sickle cell disease in pregnancy. I'm emphasizing evidence-based, but the unfortunate thing is that there's very little evidence available. So all throughout the talk, I will try and remember to tell you where there is evidence and where there isn't, but I will tell you what the best practices thus far are. And I'll also let you know that we're working on trying to make evidence available as quickly as we can, even if it's just in cohort studies as opposed to randomized controlled trials. Thank you again. So I'm going to be speaking along this outline, background on sickle cell disease generally, just a brief one. Then I'll be talking about the antenatal care in an LMIC setting, such as ours, pragmatic antenatal care. Then how we manage acute chest syndrome in pregnancy. I'm going to do a case study just because this is one thing that can occur in any of our general secondary or tertiary level hospitals. Management in specific settings such as antenatal, during admission, during sepsis. I'll talk about IUGR and some pathophysiological concepts and studies briefly, and then fetal surveillance, delivery, and postnatal care. So it's a robust one, but I'll try and be as quick as possible so that there will be time for questions as well. So as background, we know it's sickle cell is a hemoglobinopathy caused by mutation in the beta globulin gene, and it's inherited autosomal in the autosomal recessive pattern. We know that if somebody has AS and their partner has AS, there's a 1 in 4 risk of developing sickle cell disease for each pregnancy, and not that one child out of 4 will have it, but for each pregnancy the risk is there. Now Nigeria has the highest number of people living with sickle cell disease generally. 150,000 individuals born with sickle cell disease annually in Nigeria, according to the latest figures, and worldwide, we're still the highest. And that's why the care I'm talking about will be pragmatic, because this is part of where we have it the most. Now, pregnancy in sickle cell disease, under 5 mortality is still high. In fact, latest figures by Nodu et al. Are still seeing close to 50% of children with sickle cell disease dying before the age of 5. That is still the case. But many are now surviving to pregnancy. Many more children are now surviving to pregnancy, because in the far past, it was much higher than 50% under 5 mortality. Pregnancy and delivery are complicated by a number of conditions, including higher number of vaso-occlusive crises when you compare them to non-sickle cell women, urinary tract infections, spontaneous miscarriages, I'll speak more to that, acute chest syndrome, hypertensive diseases of pregnancy, and then you also have things like malaria, you have thromboembolic events, and you have frequent admissions. I highlighted the ones above because those are the ones that there's data on. There's evidence showing that those 5 conditions are more frequent than in non-sickle cell women. And then it's also known to be a frequent cause of maternal death, and that's also evidence-based. And for the fetus, we have a higher risk of prematurity. We have a higher risk of low birth weight, intrauterine growth restriction, as well as increased perinatal mortality. But we also know that despite all these dire sounding things, including increased perinatal death, increased maternal death, the prognosis for sickle cell disease in pregnancy is getting better, especially when there is multidisciplinary care and individualized care. And I'll explain that a bit more as I go along. And there's also been studies showing that multidisciplinary care does improve the prognosis in them. Now, for as far as antenatal care is concerned, mostly we do the usual routine care, but as we know in our environment, cost is a concern. So what is important to do, and I'll show a table on antenatal care next, make sure that when a woman comes in, her vital signs are done regularly. You know, sometimes women come to antenatal clinic and we only do blood pressure and weight. But for sickle cell disease, we must do their vital signs, the other vital signs, check their pulse rate, check their SpO2, check their respiratory rate, check their blood pressure and the weight. So all the 5 things: respiratory rate, pulse rate, blood pressure, temperature, as well as the SpO2. Even if you can't do temperature, usually you'll be able to feel that, but the SpO2 is important. Abdominal examination, including the liver and the spleen, checking for enlargement of those. Symphysis height should be carefully measured and compared week on week. Hematocrit, that's a PCV at each visit, and also remember to give them their malaria prophylaxis. We tend to use proguanil, but we actually don't have evidence that sulfadoxine pyrimethamine is better or worse. And since they can take it, if they can't afford proguanil, I think it's important to ensure that they take something. So sulfadoxine pyrimethamine, which is monthly, is probably okay for them as well. Ultrasound is done to confirm dates, 18 to 20 weeks, and as indicated thereafter, although this is just pragmatic. Ideally, if the woman can afford it, from 24 weeks, she should be having more frequent ultrasound scans to rule out the IGR, which is common in them. Routine antibiotics as given in, so the British Society of Hematology has a guideline out that came out, I think, in 2021, and they feel that you should give penicillin V and you should give iron and so on and so forth. Some other guidelines, maybe it's not the BSH, but there's 1 or 2 guidelines that have come up with that. First of all, we know that in children, it's shown to be an advantage to give them routine, prophylactic antibiotics. However, we don't have that evidence in adults or in pregnancy. It's expensive, and we're not sure that they'll take them. We also don't routinely give aspirin because sickle cell disease is a moderate risk for preeclampsia. It's usually if it's combined with another moderate risk, for example, if they're over the age of 40 and so on, that aspirin is advocated in this case. In some parts of the world, also in the BSH guidelines, they do advocate because of even though the evidence is not out, which I'll speak to later on, that they tend to give them 75 to 50 milligrams aspirin. So this is a table showing a pragmatic ANC care decision, basically. The first row, of course, the usual detailed history for their first visit, and then you do your blood pressure, weight, height, oxygen saturation, physical examination, cardiovascular check, abdominal examination to examine the uterus, hepatosplenomegaly, and breast examination. And then for investigations, blood group, full blood count, urinalysis, HIV, hepatitis B and C, VDRL, and obstetric scan for dating if date of last menstrual period is not known. For drugs, malaria prophylaxis, proguanil, folic acid, tetanus injection, and then consider sulfadoxine pyrimethamine and low-dose aspirin. And you counsel for prenatal diagnosis for fetal genotype if their partner also has hemoglobin S. Plan for mode of delivery as early as possible, pain relief during labor, and then document your findings on the case note. Subsequent visits, we advocate 2 weekly till 28 weeks and thereafter weekly. However, it's not evidence-based. It's just what we feel that because they are more likely at risk of complications, we should see them more frequently. So we should see them more frequently. Sometimes this is a bit difficult for them. They live far away. They don't want to be coming to hospital all the time. So if they're well, you can spread out their visits, especially in the early first and second trimester. And as the later trimester comes on, third trimester, then you need to see them more frequently, definitely, because complications occur all of a sudden. So if they're well, you can space out. If not, you still need to see them really frequently. New symptoms, weight, and so on, as written there. Packed cell volume, each visit is important. If they can afford it, then they can have the complete blood count. Then malaria prophylaxis, as written above. Sorry, I'm just trying to move something here now. Yeah, fetal anomaly scan at 18 to 20 weeks, and the regular scans I was talking about earlier. Birth preparedness, like any other patient, family planning talks, and conclusion about timing of delivery. So special points: plan for delivery and try to conclude on the mood as early as possible. Monitor SpO2 carefully each visit and consider action when less than 95%. White blood cell is often higher in them in pregnancy, also more than the non-pregnant and more than HbA women. So it's important to note that and not feel that once HB and white cell count is more than 12,000, 11,000, that there's definitely a problem. You have to monitor it, and if there are other issues, if there are no other issues, then you can leave them be. Automated machines also sometimes erroneously interpret nucleated RBC as white blood cell. So that's why it's important to take note that there is that possibility. If you're trying to decide for sure about bacterial infection, procalcitonin is an option. Before I move away from there, I want to just highlight multidisciplinary care again. If I haven't already. Multidisciplinary care is very key in these women, antenatally and at other times. And it's important to engage your hematologist because not every team, especially in the secondary centers, most of the time you don't necessarily have the team that are versed in sickle cell management, and so the maternal medicine team. So it's important to try and engage your hematologist. If you don't have a hematologist as well, that's one of the reasons why some of these lectures are necessary. And we're very happy to have people refer women with sickle cell disease that you have issues with to us in Luth. We always take them very, very happily. So please refer them to our unit if necessary, or reach out to us to discuss problems if you have them with them. Because, yeah. So a clinical case, a 33-year-old woman with hemoglobin SS in her first pregnancy presented with a cough, severe knee and lower limb pain bilaterally, and severe oligohydramnios at 34 weeks gestation. So cough, lower limb pain, severe oligohydramnios. On examination, she was dehydrated, temperature normal though, pulse rate 100 beats per minute, respiratory rate 22 cycles per minute, SpO2 88% in room air. She was admitted, she had a chest x-ray done with abdominal shielding, and oxygen was administered with a rebreathable mask. A complete blood count showed an HB of 5.5 grams per DL, white cell count of 22 times 10 raised to the power 6 with a neutrophilia of 81%. The patient's chest x-ray showed radio opacities, as in this diagram. Despite an increase in the oxygen flow rates, giving her antibiotics, ceftriaxone 1 gram twice daily, giving her a top-up transfusion of 3 units of packed red blood cells within 24 hours, her HB level had only increased to 6.2 grams per DL, and she remained oxygen dependent. She subsequently had a manual exchange blood transfusion, EBT, with 6 units of ABO-compatible, HBS negative, packed red blood cells. Her post-exchange HB concentration within less than 48 hours was 8.6 grams per DL, and HBS fraction was 22.3. Now, that case was brought up to highlight the problem of acute chest syndrome in pregnancy. And I'm going this far, although I'll still go back to regular management. So don't be discouraged. I'm going this far because acute chest syndrome is one of the worst things that can happen to them. It's one of the commonest causes of death in them. And so it's important to have an idea of how to manage it to reduce the risk of the mortality from them. So the definition is when a woman with sickle cell disease has fever or respiratory symptoms with new infiltrates on chest X-ray, and it's a known cause of up to 80% of maternal deaths. Now, what causes it? We think it's sometimes just a follow-up to infection in them. So pneumonia is definitely seen. It's one of the predisposing factors to acute chest syndrome. We think fat embolism is also a possible precursor to it, as well as infections, other infections apart from pneumonia. It also often follows vaso-occlusive crisis. So when a woman comes in pregnancy with vaso-occlusive crisis, especially towards the later stages, it's important to really treat them aggressively and early so as to prevent their progressing to getting acute chest syndrome. Early and aggressive treatment is important with multidisciplinary care. It's often difficult to distinguish it from pneumonia. So if a woman comes in with seeming pneumonia, then it's best to treat them as if they also have acute chest syndrome, since sometimes we can't even get the diagnosis as quickly as we would wish. We should involve a hematologist if possible, a respiratory physician, microbiologist, and a maternal medicine lead if we have one. And at least an obstetrician, even if you don't have a maternal medicine specialist. So how do you treat acute chest syndrome in pregnancy? Broad spectrum antibiotics for atypical organisms. So that includes giving azithromycin and co-amoxiclav. Okay. If the woman is really very sick and you are very worried, you've given these drugs for 48 hours, I would switch or at least include levofloxacin because it's seen to be something that tends to work for them. Oxygen should be given very early. Sometimes that's what saves their lives. Intense ICU care if you have it, and if not, transfer to one as soon as possible. In mild cases, give your simple blood transfusion, exchange blood transfusion for severe or those that don't respond to simple transfusion. We use manual exchange blood transfusion in our center, and we use the number of units as opposed to the patient's weight. It usually works when we do this, but we know that it's not common that you will always have the ability to do exchange blood transfusion. So the important thing is to at least make sure you give them blood, packed cells specifically. You have to be careful so as not to overload them. And for women with acute chest syndrome, if they've had it in pregnancy, after they deliver, it would be a good idea to try and ensure you start them on hydroxyurea because the risk of recurrence is high. Now, in very low resource settings, oftentimes that occurs with us, women with vaso-occlusive crisis may suddenly develop respiratory symptoms. When they do that, just also assume that they have acute chest syndrome until proven otherwise. So treat the VOC very early. Transfuse with HbAA red cells, packed cells. Ensure adequate rehydration and fluid balance. And when I say that, that's another point that we have to be very careful about. Hydration and fluid balance with sickle cell disease women. Please, please, please don't rush in fluids and leave it and forget them, because a lot of them have tendency for preeclampsia, and you know that giving them fluids floods their lungs. Some of them also have cardiac and renal disease. Also giving them fluids indiscriminately can be a problem there. So it's important to keep a strict input-output chart for them. Give them 500 mils plus the previous day's output. And if they're just coming for the first time, start them on a pint, 500 mils quickly, but watch their urine output. Once urine output is great, tailor it to that urine output. Look towards maybe about 2 liters at first, daily, in one day, because they are small, don't forget. And ensure that you do the input-output chart. Every 12 hours, check your fluid regime. And that's part of the problem. We write a fluid regime for the day, and we forget about it and just let, especially since we use gravity fluid bags, we forget about it, and it's the next day that we are saying, oh, what's the input output? No, we should do it 12 hourly so as to not overload them, because with them, every minute counts, every hour counts. You may have lost the chance not to overhydrate them if you wait till 24 hours. So it's very important. As soon as they can drink, let them start drinking and start reducing your fluids even more. So that's very important. If their urine is concentrated, hydrate them. If their urine is very light and dilute, after your first 12 hours, regulate the fluids and let them drink. And once they are dehydrated, or once you are trying to resuscitate because of fluid depletion, using 4.3% dextrose in 0.18 normal saline is good, because it's a hypotonic solution and stays in the bloodstream sufficiently. Preconception care. So going back to management in different settings, what I've said so far and what I think is very important to remember is that vital signs are very key in these women antenatally when they're on the wards. In fact, that's what I think made a big difference to care for us generally in Luth. We started paying attention to their vital signs, every single component of it regularly. Hour on the hour. We are very, very particular about that for our patients. And so every hour and hour, we're looking at those vital signs. SpO2 is also important, because sometimes everything may seem okay, respiratory rate fine. Meanwhile, the SpO2 is low. When that is the case, they may need to be admitted for that reason. So management in specific conditions, preconception, for example, it's important to make sure that if they come to you saying they want to get pregnant, make sure that their blood pressure is normal. Make sure that they don't have proteinuria, whether microscopic proteinuria or otherwise. And you can identify microscopic by doing their protein creatinine ratio and do their renal function test. This is because they are prone to renal disease, and it may progress to end-stage renal disease if you don't monitor it. And proteinuria tends to worsen in pregnancy. Another thing that we don't do routinely, and which we should try, especially if a woman comes to meet us before she gets pregnant, is to screen for pulmonary hypertension, because they do have a higher risk of it. And even though we feel when they come, they're fine, since she has come here, they may have underlying pulmonary hypertension. And if they do, it's better to try and dissuade them from getting pregnant, unless their ejection fraction is very good. And you will have to involve a cardiologist there. Full blood count to check their steady state HB. If it's low, tell them to delay conception and treat. And delay conception if they've just had a recent crisis or transfusion. Discontinue hydroxyurea, that's another thing, at least 3 months before conception. If it is in use already, just counsel them that it's probably okay, but they should stop it. Screen their partners and give them information about pregnancy. Avoid dehydration. Always make sure they avoid extremes of temperature, and and to ensure that they book early when they get pregnant. Now, management, antenatal, we've spoken quite a bit about this already, that multidisciplinary care. One thing I didn't emphasize was the issue of the folic acid. 5 milligrams daily is actually enough. Folic acid, we use a lot more than we need in pregnancy. So 5 milligrams daily is okay for them, and proguanil should be about 200 milligrams daily. Or like I said before, sulfadoxine pyrimethamine if proguanil is not available. At each visit, we've talked about this. They should drink water liberally. We should examine for other symptoms. We should take their routine drugs regularly, and we should tell them about temperature and frequency of visits. Now, we've talked about ultrasound as well, to be done at booking, 18 to 22 weeks pregnant, and the frequency of antenatal visits. And now to talk about if they can't afford the scans, which a lot of them can't, careful symptophonal height and scan when indicated. Admission should be effected in certain situations. If there's a confirmed sudden packed cell volume drop, e.g. more than or equal to 3% between corresponding consecutive visits, if it's 3% less than their steady state, or if it's below 18%. Now, this isn't evidence-based, but it's just one of the things we found to be useful in taking care of them. If they have a febrile illness, if they have a sickling crisis, any of the sickling crises, and if there's any other obstetric or medical indication that distorts the vital signs or is not amenable to conservative management. So for example, they have placenta previa and they're bleeding or something like that. I'll also talk briefly about the management controversies. Hydroxyurea is supposed to be stopped when they get pregnant. Once in a while, especially later in pregnancies, second or third trimester, we have some women who have had significant recurrent crises. And sometimes this is what helps, either hydroxyurea or an EBT. So it's exchange blood transfusion. So it's important to take note of that, that may be needed, but it should always be in consultation with a maternal medicine expert who is used to looking after these women. Prophylactic antibiotics, we mentioned that already, that it's not something we do in our environment because they're expensive and they are not necessarily evidence-based, useful for pregnant women. Iron is another one. We've always been told women with sickle cell disease should not be given iron, there's no need, and so on and so forth. However, we do know that every pregnancy, there's a developing fetus and there's a requirement for additional iron in pregnancy. Yes, we know that women with sickle cell disease tend to be iron replete. However, being iron replete does not mean that they have overload. So if a woman with sickle cell disease comes into pregnancy, she's never had a transfusion in her life, and there are quite a few of them like that. And transfusion is one of the things that increases the iron load in them. So she's never had a transfusion in her life. She's had very few crises. That means she's also not really breaking down her blood cells that frequently. It's quite possible that this woman could be iron deficient in pregnancy. So one of the things that you should try and do is to check for possibility of iron deficiency by doing just a full blood count in the first instance. And if they have microcytic hypochromic anemia, red blood cells, and they seem to be anemic, then you can give them a simple dose of iron. Or we had some patients like that when we were doing our trial, and we found out that somebody in another center, this woman just had, her HB was just low. And they gave her folic acid, did everything. It wasn't terribly low. It wasn't yet time for transfusion, but she just seemed, as if things weren't okay. So when checking her ferritin and all the other iron markers, it was found that this woman was actually iron deficient. And we gave her iron and her blood count improved. So sometimes it's possible that their blood count may improve if you give them iron once you're sure that, they have... they're actually iron deficient. Prophylactic blood transfusion is another thing. We don't do that in Nigeria, and so the previous reviews showed that it was only effective to reduce the number of crises, the frequency of crises, but did not reduce the important maternal or perinatal outcomes. However, I know that colleagues in the global north are beginning to look more into prophylactic blood transfusion. They actually have, the facilities to do the proper cross-matching. They have adequate amount of blood and so on. So it's possible for them to go this route. For us, it's a bit more difficult, and that's why it's still controversial with us, and the evidence still does not really support it anyway. It's just that we know that some people are looking more favorably towards it in wealthier countries. So for admission, management of admission, careful hydration, like I've said before, invite hematology units early, especially when they have a crisis or any type of crisis, particularly vaso-occlusive. Daily or twice daily PCV checks. Vital signs, I'm highlighting it. You can't overdo vital signs with women 6 30s. Ideally, we should have a monitor attached to them, but because we don't have a lot of monitors, doing those vital signs and all the 5, none is less important than the other. Respiratory rate is very important. Pulse rate is very important. Even though there's tachycardia in pregnancy, if you compare it to their baseline pulse rate, if you're recording it all the time and you see that suddenly their pulse rate has gone really high, there might be a problem, and it's not just pregnancy that's causing it. Same thing with the SpO2. It's important to be monitoring these things and to also chart them. Analgesia is another thing I've highlighted. In the first trimester, ideally, the evidence is not from women with sickle cell now. Generally in pregnancy, we are supposed to avoid non-steroidal anti-inflammatory drugs in the first trimester because they've now been shown to increase the risk of miscarriage, spontaneous miscarriage. And also for the after 31 weeks, we're also supposed to avoid them because of premature closure of the ductus arteriosus. But I know that we tend to give NSAIDs to sickle cell, women with sickle cell, because of their pain tends to respond to it quite a bit. But let's be careful in those gestational ages between in that early first trimester. If there's no other option, yes, go ahead and give it. But if there is, use the other options. Starting with paracetamol, then the paracetamol mixed with codeines, and then move up to your regular opiates and pentazocine, morphine if available. Pethidine is not advised in them because it's been found to cause seizures when it's given in a particular dose. Transfuse with packed red cells. Always try to ensure that the cells are packed so that you're not giving them too much fluid, unnecessary fluid. Also, we know that packed cells, whole blood is more likely to cause transfusion reaction than packed cells because of the plasma aspect. HbAA blood is preferred so that you're trying to give them more AA and not, you don't give them HbAs. And in case of severe anemia below 18%, you're trying to raise the hematocrit to steady state if known. For sepsis or pneumonia, frequent full blood count to monitor white blood cell chart, make a chart so that you're seeing the progression of the white cell. Is it going up? Is it going down? It's very useful. Please don't be afraid of doing chest x-rays for women with sickle cell disease. We tend to be very afraid of chest x-ray for pregnant women. Please, this woman is important herself as well as her baby in the first instance. Secondly, the amount of radiation from a chest x-ray is very, very minimal. It's not likely to do anything to that fetus. And to give you more comfort, please do abdominal shielding. SpO2 with vitals, if less than 90 or equal to 94 patient's known values, make sure you give oxygen. Procalcitonin is a marker that helps to differentiate bacterial sepsis from viral sepsis or pregnancy-related rise in white cell count. So it's important it can be useful in a lot of cases. As I said before, augmentin or erythromycin for chest infection to cover atypical organisms. Quinolones like levofloxacin may sometimes be necessary, and multidisciplinary care. So I think I'll skip here, but going back to the clinical case, I think I've done about almost 30 minutes already. I'll do another 5 or 10. A growth scan showed that the fetus was small for gestational age, and although the fetal umbilical artery Dopplers were normal, non-stress tests revealed recurrent bradycardia. Dexamethasone was administered for fetal lung maturity, and emergency CS was performed. Fetus weighing 1.8 kg was delivered, and the patient recovered well and was discharged home after 5 days. So previous work, we found that plasma volume and plasma renin concentration was unchanged in sickle cell pregnant women. On the right part of the slide is where you have the sickle cell women, and this is not pregnant. This is 16 weeks, and this is 36 weeks, and we're measuring plasma renin concentration here. But this was exactly what it looked like too for plasma volume, and you can see that at 16 weeks. It rose a bit, but by 36 weeks, there was no difference at all, unlike the HbAA women. We went on to now look at, we figured that might be due to possibly increased peripheral resistance in women in sickle cell disease. So we went on to look at the prostacyclin thromboxane ratio, and we found that there was a reduced prostacyclin, a changed prostacyclin thromboxane ratio in women with sickle cell disease compared to their HbAA counterparts. And this is similar to preeclampsia. So we went on to now looking at the current study, hypothesizing that similar to preeclampsia, aspirin will reduce the risk of IGR and preeclampsia in pregnant women with sickle cell disease. In this case, we're looking at IGR as a primary outcome and not just preeclampsia. And we're currently 90% of the way in recruitment for this trial. We hope to be done at least by March, by God's grace, so that we can know whether 100 milligrams of aspirin is effective in reducing the risk of IGR, miscarriages, preeclampsia, and perinatal deaths in pregnant women with sickle cell disease. So this is the protocol that we published in BMJ Open, but we're still waiting to finish the trial itself. Now, surveying the patient, the pregnant woman with sickle cell disease is difficult in LMICs because of the equipment, the cost, and also the expertise in doing things like Dopplers. So you monitor the growth with two weekly from 28 weeks if it's available. If it's not, like I said before, sinusoidal height carefully. And once you feel that it's dropping off, then it's important to find a way of doing their scans, even if it's just biophysical profile you can do, or with umbilical artery Dopplers is more useful. And if they're abnormal, you consider delivery. If the mother's condition is worsening and there's need for resuscitation, you may consider delivery too, as soon as you resuscitated her, and if there's fetal death. If the acute chest syndrome resolves, pregnancy should be carried to term if the mother and baby are stable. Birth. Vaginal birth is preferable. There's no evidence to that, incidentally, but we know that the risks with vaginal birth are generally less than cesarean section. So when you're looking at it from that point of view, vaginal birth is preferable for them as well. Timing of birth, there's also no evidence, but we feel we've rationalized that earlier birth might be preferable, especially for those who have complications throughout their pregnancy, always having crises. You might want to deliver them early, by 38 weeks at the very latest. Multidisciplinary care as usual, hydrate and give oxygen. During labor, you should try to get an epidural for them if you can. If not, morphine. Pentazocine is okay, but it's really not as useful a painkiller, especially during labor, as these other analgesics. And I know people think about addiction. These women actually don't get addicted as frequently as we like to believe, and they often need this pain relief. As soon as possible, though, get them off it so that they don't build compliance to it or tolerance to it. HbA, I can't overemphasize that, and then you make sure we do the hemoglobin concentration and regular vital signs and urinalysis to monitor them. Cesarean section is common for them, unfortunately, due to obstetric and sickle cell related conditions like preeclampsia, like avascular hip necrosis, making it difficult to abduct their legs during labor, obstetric or sickle related complications as well. It's important to give them steroids when they need it for reducing respiratory distress and perinatal death. It shouldn't, it's not contraindicated in them. Please give it. Thromoprophylaxis is very important. So if they're admitted during pregnancy, we always give them Clexane. And immediately after delivery, whether it is vaginal birth, whether it's cesarean birth, we give them Clexane as well. There's a longer period before discharge, usually because of postpartum risks, but that's not evidence-based either. We tend to want to keep them. For vaginal birth, we keep them for 4 days usually, but I think the jury is out as per whether you should lock them in if they are doing well by the 3rd day. Last slide, postpartum, early testing for sickle cell disease in the baby. We should maintain optimal maternal oxygenation and hydration. We should make sure that we give the thromoprophylaxis, like I said, and we should monitor for crisis complications for 4 days. Contraceptives, in particular, progesterones, are effective and safe, and Depo has been shown to decrease frequency of crisis in them, although Depo has its own problems sometimes. But the other progesterone-only contraceptives like Mirena, Implanon, progesterone-only pill are also good for them. They can use barrier if they can't tolerate any of the hormones, but we know that there's a higher risk of pregnancy if you use barrier methods. Combined pills, IUCD, are not absolutely contraindicated, but we should avoid them because of the risks of thromboembolism and also heavier bleeding that you get with IUCD. That's copper T IUCD now. If they've completed their family, it's important for you to try for them to have a BTL. So in conclusion, managing pregnant women with sickle cell disease in resource-limited settings can be challenging to both the woman and the care provider. High mortality can be reduced if we can devise strategies to implement healthcare using our available resources in a cost-effective and evidence-based manner, as was done in the clinical case that we presented. Thank you very much for listening, and I'm sure that there are loads of questions which I'm happy to answer. These are my references. Thank you.
All right. Prof. Ande has appealed that I continue with the moderation. I think he's having some internet challenges. So I'll continue. I'll start by thanking President Professor Bibi Afolabi on a very detailed, down-to-earth lecture that has given us a pragmatic approach to the management of sickle cell disease in Nigeria, bearing in mind all the prevailing constraints that we have in the country. We have several questions in the chat box, and I want us to quickly move through them so that we take all the questions, and then maybe if we have more time, we'll have this extra, because we want to make sure that this webinar lasts an hour, which is the time that has been scheduled for it. So do
Should
I
I
go
start
over
with
to the
the
questions for you? Yes,
No,
ma'am.
I can see them. Starting with Dr.
Uh-huh.
Ayeke, I think that's the first one. Dr. Ayeke says that in the US, colleagues are reluctant to transfuse SC patients, specifically SC and not SS, okay, especially when there was a previous history of reaction to blood transfusion. EBT, therefore, is rarely an option in such cases. So what other options can be used in a pregnant SC patient with acute chest syndrome and low HB? Will erythropoietin be a consideration? Yes, certainly. Erythropoietin is a consideration even for the SS ones. I wasn't aware about the reluctance to transfuse SC patients though, and I'm not aware that they have more issues with transfusion reaction than the SS patients. If that is the case, then definitely it would probably be better to keep away from it. However, what I know and I've heard from some of the colleagues in the global north is that because they are better at doing all the cross-matching all the Kelly and Duff and all the different small other blood factors that we are not able to concentrate on here, they give transfusions more regularly. But your question about erythropoietin, yes, we can use erythropoietin for some patients, definitely. Thank you for that. The next question I can see here is to deliver that level of care in Luth. How did we get our nurses on board to deliver that level of care? Or maybe there's a special word. Fatima, the truth is that house officers become our nurses in this case. And we generally tend to, to make it our house officers that are giving us back our feedback, unfortunately. But yeah, it is a difficult one to get that level of hourly care on the open ward. Another thing we do is that we have a dedicated HDU in labor ward where we have a monitor. So we use the monitor there for patients that are prenatal. For postnatal, it's a bit difficult because of that issue of not wanting postnatal patients to be on labor ward, but we still try to keep them there, and we discuss with the nurses to say, look, this patient has to stay here. So since that the monitor is not so difficult. Need for prophylaxis at every admission. Yes, if a woman is staying on admission and she's sickle cell, which already has a high risk of thromboembolism, she's pregnant, that's another risk, and she's now immobile as in admission, yes, she needs to have thromboembolism. Levofloxacin is safe in pregnancy. It is. It's as safe as, I know we used to avoid quinolones as much as possible, but we actually know that in newborns, they actually use levofloxacin in newborns. And in this case, we're talking about a woman who is very sick, who has acute chest syndrome or pneumonia that can progress to that. We prioritize her health and we give levofloxacin, and we haven't seen it cause problems in the fetuses. What about antenatal iron in them? Do you consider it at all in all or select cases, or is it a no for everyone? I think Hawa probably didn't hear my talk on that or my mentioning that. We do consider antenatal iron if they haven't been transfused before and if they don't have a lot of crises. But we also check their blood count, look at the mean corpuscular volume, and try and see if there's evidence of iron deficiency. If they can afford it, I get them to do an iron profile. And with that, you can see if ferritin is sometimes raised in them even when they have just normal iron, because it's an acute phase reactant, and they themselves are usually in an acute phase of inflammation. So sometimes it's the other types of iron determinants like transferrin saturation and transferrin that tell you, or total iron body concentration, that tell you whether this woman has low iron or not. Sulfadoxine pyrimethamine is, yes, it's monthly as for general pregnant population where progranil is not available or if it's not affordable. If a patient reacts to sulfadoxine pyrimethamine and progranil is not available, yes, you can give them the what's it called? What's that? Coartem type drug. There's a name for them. Artemisinin combination therapy. Yeah, for them monthly. Then should pain management rest with the hematologist or obstetricians? Well, I think it depends on who the obstetrician is. If you're not conversant with looking after them, then yes, it should definitely be the hematologist because they know better and they've seen them more. But I also challenge a lot of the hematologists, apart from the ones that I work with, because we know our work. They are used to seeing pregnant women with sickle cell, and we also are used to working with them on it. So we've learned of each other, and our hematologists are excellent. But outside of that, it's sometimes possible that hematologists that don't work with them regularly don't necessarily know how things work with them. So for example, this ferritin thing I mentioned, there was somebody that told me, a patient told me that her hematologist, which was in a private area, told her that once ferritin is raised, it means that she has iron overload. And I said, no, that's not necessarily the case. In women with sickle cell disease, in pregnancy, ferritin does tend to be raised. So it's possible that they are just okay in their iron level, and it's not overload. You need to do the other panels, the other iron panels, transferrin saturation and total iron body concentration, to be sure that they definitely are not iron overloaded. Apart from that, in terms of pain regime, we tend to see, sometimes you can have suboptimal pain control when you've given them all the opiates, all the analgesics, including the NSAIDs, everything. Sometimes such women may need to have an EBT. I remember seeing there was this woman who by 20 weeks, she was on her fifth crisis that she needed to be admitted for. And she was crying in the A&E, and she had morphine, parenteral, she had non-steroidal, she had everything. What eventually sorted this woman out was an exchange blood transfusion, after which we started her on hydroxyurea. So sometimes when you do have suboptimal pain control in them, yes, invite your hematologist if you're not used to looking after them, but you do, sometimes it may just that no pain relief is working for them. Then steady state. So steady state just means if what they know as their own regular HB or PCV, sometimes they may not know it, so you may not have that steady state. So that's what steady state means. That when they are not unwell, when they are not pregnant, what is their usual HB? It differs for every patient. In a center where there's only obstetrician and no other multidisciplinary team, is it advisable to manage sickle cell disease patients in such scenario? Well, it's really up to your own knowledge. If you feel uncertain, then refer. Like I said earlier, we are very happy to look after them in Luth, so you can refer them to us quite easily, to my unit. Or if not, refer them elsewhere once you're not comfortable. I think it's better to do that than to look after them yourself. Is there a tool available for assessment of tolerance to opioids? I think we shouldn't bother ourselves too much about this tolerance or what's it called business. I had a patient who was actually addicted. It was clear she was addicted. And that's just one or two out of the many, the hundreds that we've managed. But this one she was clearly addicted. And we were talking to her on a regular basis, talking to her husband. She was taking it at home. But she insisted that once she's not pregnant, she's not going to be taking this thing. We got psychiatrists to see her, so that they we admitted her, got psychiatrists to see her, so that they started looking for the opiates that would be less likely to be addictive. And, we got them, and that seemed to help. But the thing is, you cannot ignore their pain. You cannot say, oh, because you think they're addicted, they do not take pain relief. I know there's also the issue of the baby, because the baby too can be affected by the opiates. But at the end of the day, this woman is crying in pain. Are you going to say, oh, I'm sorry, you're addicted, I'm not going to give you pain relief? Such patients are the types that you may want to give your NSAID injections, give all the other things available, but you can't really deny them pain relief. Is clavulanic acid combination drug now generally acceptable for use in pregnancy? Oh, yes, definitely. It's always been amoxil, clavulanic potentiated amoxil, that is augmentin, or similar drugs are definitely acceptable for use in pregnancy. What are the early markers of acute chest syndrome? Key management interventions. We spoke about that, sorry. That was a major part of the lecture. Basically, infiltrates, when you have a VOC, it's very easy to move to it. It's similar to pneumonia, and it's something that once a patient has any chest symptoms and she already has a VOC, assume it's acute chest syndrome until proven otherwise. There's also, of course, the proper x-rays that help you define it. Outcome of Sickle, we use 100 milligrams because the women were small. And even now, Soraya, I also think to myself, I wish we had used 150, but it was too scary. This was a clinical trial in Nigeria. And it was bad enough that we're leaving the safe 75 milligrams that everybody knew at the time. We started this trial 3.5 years ago, by the way. So at that time, we weren't giving aspirin, yafu like that. The 150 milligrams wasn't really that well known. And we wanted to be sure that, because aspirin is dose dependent, the side effects. So the higher the dose, the more likely the woman is to have effects like bleeding. And these women are small. You know that most sickle cell women are very small stature. Their BMI is quite low. That's why we went in between 75 and 150 and chose 100. Is there a place for cervical ripening induction? Certainly there is. We induce a lot of our patients with sickle cell. Once they're term 38, 39 weeks and there's no problem, we do induce them. Thank you. What's the current standard protocol for PCV liver spleen monitoring? Just monitor it every visit, basically. Does benefits outweigh risk for chest x-ray in SCD women with suspicion of acute chest syndrome? Benefit outweigh risk. Definitely, I did say that even for any pregnant woman, if you feel that you may be having pneumonia, do a chest x-ray. It's not really as dangerous as we think. Do we still advocate for limitation of family size of a second childbirth? There's no evidence to support it, but I still try and tell my patients, please stop. This thing affects your life, but there's no evidence for it. We just try and appeal to them. What dose of pethidine? I think we should just avoid pethidine. In the first trimester, thank you, ma'am. What's the number of delivery they are advised to have? Like I said, preferably 2, but it's up to the woman, but just try and tell her to limit it. Duration of stay postpartum, we usually say 4 days. It's not really evidence-based, but we say it just to keep an eye on them. Antibiotics and thromboprophylaxis postpartum is not routine to give them antibiotics if they don't need it for any reason. Thromboprophylaxis, definitely, Clexane should be given postpartum. Pethidine is because of seizures. Presentation, yes, I'll send it to you. What time is it now? Okay, we still have a few minutes. We'll soon be done. 4.3% D-saline is hypotonic. That's why. SS patient be allowed to pass her due date. That's more than 40 weeks. I didn't know. I mean, we don't have the evidence, but if once a woman is 39 weeks, it's already seeming that if you induce them, even non-SS, the likelihood that they'll be okay is fine. So they definitely shouldn't be past their due dates. Encourage all women to book for antenatal care in the first trimester. Yes, I agree with that as much as possible, especially for such women. Shorten second stage of labor for all women with SCD, not routinely if they are pushing well and everything is going well. But they should be on good analgesics, including what we tend to do when we give them epidural, because they find it difficult to push anyway. We do try and shorten the second stage of labor, but some of them just pop the baby out. So the important thing is to be ready to shorten it if necessary. Yes, somebody agrees with me regarding the iron. Maternal blood test for in utero fetal HBSS status detection. That is, I think you mean NIPT for Dr. Agbedia. Is not really that available. There's one person that is advocating it these days, but I don't know how accurate it is. But the chorionic villus sampling is definitely there that they do at the Sickle Cell Foundation, and I'm so sure of that one. How do we check their PCV during labor and postpartum? You can do HB, hemoQ, and you can also do a full blood count. Proguanil is the preferred prophylaxis. Well, the truth is that we don't know what the preferred is, but this is what we've always done. The evidence is not there. I was trying to get a grant to look at it, and one of these days I still will, to look at proguanil versus sulfadoxine pyrimethamine, because proguanil is really expensive. Gene therapy in their management, not yet. The studies haven't been done in pregnancy in terms of gene therapy. Immunization and aspirin during antenatal care. No immunization. We don't have the regular immunization like tetanus toxoid is done, but we don't give pneumovax. And we've spoken about aspirin that it's on a case-by-case basis if the woman has several risks apart from another risk apart from a sickle cell. We're still doing the trial. We don't know what's going on yet in terms of PPH, so we haven't completed it. Wow, there are a lot of questions. Yes, we're looking at that risk of running. We hypothesized that it was due to that, and we're looking at we looked at thromboxane prostacyclin ratio as well in them. Yes, we can share the slides. Gene therapy until the studies are done in pregnant women. I think that's it for the questions. Wow, that was interesting. Over, Dr. Raji.
All right, thank you once again so very much for the lucid presentation. And yeah, we can see the amount of interest we have been able to generate from all the questions that have been taking out time despite their busy schedules. I noticed that when we're starting, I think we're about 50 of us that started with the webinar. And now we're rounding up, we're almost 200. All right, so unfortunately, a lot of people miss quite a bit of information that they would have benefited from if they'd been able to join in earlier. So I just want to appeal to us that for future webinars, AFEMSEN usually tries to stick to time. So you will not be disappointed. Please join in early and take part in our future webinars. I believe the slides will be available on the AFEMSEN website. Am I correct, Ma?
Yes, they will.
Yes, so you can check the website maybe in a few days or so, www.afemsen.org for the slides of this webinar. So it's 1 hour. We pride ourselves on finishing on the dot of an hour. I don't know whether anybody has any final comments, maybe from
I think Prof. Ande has his hand up, but then we're also advocating people to join AFEMSEN. So please,
yes,
join.
That's why I said I will have a few more minutes. Yes. Prof. Sandy, you have the floor, sir.
Well, very sincere apology, I couldn't join. I've prepared so much. Maybe the preparation was too much because I wanted to let people know what our president is doing and the stimulation she has brought to all of us. But I joined later and I really enjoyed the presentation. Although we know we're in between the old generation and the new ones. There are some things you brought up that was very interesting. I'll discuss them with you, not on this floor. You get it. We have these controversies of do you give blood, do you do this, do you give iron or not? Those are areas that we have to domesticate. That's my own thought about it. Well done, well done. And please, I told my residents to join. I saw a lot of them because it's an interesting topic that you can't know it all. And the more you hear from people, the more you adjust what you think you are doing to fit in. So we really appreciate, and I'm very sorry I didn't have this good opportunity to moderate this, but I'm happy Professor Raji has done a good job. I told her to carry on. We hope to have more of this, and at least it's a learning process for all of us. Let's make an attempt to listen to each other. We have a lot of resources within us, and we can make good use of it. Thank you, my sister, and thank you, everybody, for coming on. Thank you.
All right. Yes, some people have been asking for recordings. I'm not sure whether recordings were made. If they were, then I think it's likely going to be put up on the website. So just very briefly talk a little about AFEMSEN, which is the Association for Fetal Medicine Specialists of Nigeria. We have members across the 6 geopolitical zones in the country. To be eligible for full membership, you have to be an obstetrician gynecologist with a fellowship of either of our postgraduate colleges. And then we also have associate membership, which is accorded to other stakeholders, like the neonatologists, the resident doctors in obs and gynae, radiologists, midwives, and all that are encouraged to join us as associate members. More details on both full or associate membership is available on our website. I think it's been posted on the chat box already. Yes, our president has posted our website. And then, yeah, we're also inviting you for our conference next year. It's not too early to start planning for it. Let's keep the dates. Let's start saving money towards the tickets and hotel fees. It's coming up in July 2024 in Port Harcourt. So final words, President, any final words from you, ma?
No, thank you. We've said it all. Thank you.
All right. So we've overshot the time by about 3 minutes. I hope you forgive us. Thank you so much. And we hope to see you during our future webinars. Look out for them. Thank you all.
Thank you very much, everyone.
Bye, everyone.
Bye. Thank
Bye.
you.
Yeah, bye.
Bye,
Bye-bye.
thank you.
Thank you.